Okay, welcome back to the last session in this year's healthcare track. I'm not going to take any more time than I need, but here's Eve Mailer and Debbie Bucci.
Hi, everybody.
That's so bright.
Yeah. So, all right, so we'll get started. So, and where's our slides? Back. So, hi, I'm Eve Mailer.
And I'm Debbie Bucci.
And we are co-chairs of the Health Relationship Trust Working Group at the OpenID Foundation. And we'll be building a little bit of a story for you to explain what HEART is and what the things surrounding it are. So HEART is a working group to work on a very important problem. As you know, being a human being with a body, health data is awfully personal, private, important data. We know that a long time ago, it was exclusively on paper, stored in big filing cabinets, and it's increasingly digital. Either from the start, from a device of some kind, or when it's transcribed from those big paper filing cabinets. And we've got smart devices increasingly generating some of that data. And as we know, being human beings with bodies, we want to be in control of the gathering and the sharing of that data. And particularly if we may have, say, elderly parents or people in our families, or maybe just we ourselves, we want to be in control of gathering and sharing data when we have complex conditions that require ever more of that data being involved in these conditions.
And then I would also say, if you have been following healthcare from a governance or a policy perspective, the provider-to-provider type of exchange is very highly regulated, where when you're looking at the consumer patient side, it is unregulated, well regulated under more Federal Trade Commission. So this is very much the idea of patients really, once they do get their health data, they do own it, and to give them some empowerment on how to manage that. So part of that is our focus is truly to focus on the patient-mediated exchange for some of those reasons.
Yes, HEART is uniquely in the standards landscape, focusing on patient-directed, patient-controlled health data exchange versus a kind of provider-to-provider landscape that is pretty much well-populated.
And also, we're getting to FHIR in a minute, but we also wanted to focus on health, not just health clinical data specific, understanding as we go to big data, all these there will be other APIs that will impact the work that we do.
Yeah, so thinking of health generally versus just health care formally. So specifically, what does HEART do? So its charter is to achieve restful, patient-centric, privacy-sensitive health data sharing. And so very specifically, what it's doing is it's profiling a set of specifications, some of which are security and authorization and consent-related, OAuth, OpenID Connect, and user-managed access, UMA, and also sector-specific Health Level 7's Fast Healthcare Interoperability Resources, or FHIR API. At least for a start. There may be other APIs in that general sector that may be of interest, but we're starting with FHIR. It's the most popular.
Because there's a general understanding or a growing agreement that when it comes to exchanging the actual clinical data, FHIR, the Fast Health Info Resource, is the way that data will be exchanged as the growth of APIs grow over time. That would be the standard to look to.
Yeah, it's been very popular. Who here is actually from the healthcare sector or health sector generally? So maybe about 30%. Okay, great. And for those who may have heard of Smart on FHIR, this has been an effort that is provider to provider, very popular for figuring out how people who are using healthcare applications can arrange in a provider context to hook up data sharing with applications, and we're ensuring that the HEART work is aligned with the existing, basically emerging standard in that area. So who's involved? Who's at the table of this OpenID Foundation working group? Well, it includes health and health IT subject matter experts, technology experts, and sometimes those are the same people. And so the leadership team, in addition to Debbie and myself, includes Justin Richer. You may have attended some talks by Justin this week. We have weekly meetings, bi-weekly meetings actually currently. And if you know of the OpenID Foundation and you're interested in this work and it maybe impacts your daily work, you can actually arrange to join us. So the current state of the deliverables, I know this is a bit small, so I'll sort of read to you what it says. It looks a bit fuzzy up there. Is that we have different profiles. Some of them are called mechanical, some of them are called semantic. What mechanical means in our language is that it's a security profile. It's meant to tighten down some of the options in the specs that you may know and love, like OAuth or OpenID Connect, and just ensure that for a health context, it's appropriately secure or secured. Semantic means it combines those specifications with, in this case, FHIR so far, the FHIR APIs. So if you're familiar with, for example, the financial API working group and its profiles, that work combines with those sector-specific APIs. We're combining with the FHIR APIs so far. So these are the combined APIs. We currently have OAuth, OpenID Connect, UMA 1.0 and UMA 2.0 profiles, along with combinations with FHIR. But UMA is more emerging as a standard compared to these other two, OAuth and OpenID Connect. And at this time, we're seriously considering just deprecating the UMA 1.0 profiles that we've done. So we have 7, we'll probably end up with just 5. So that's what you're seeing here. There's mechanical, 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 semantic, semantic, mechanical, semantic, and then we've got implementers draft versions, and then latest working group drafts. And these are all just, the working group draft column is just generated. The latest is generated when you go and click on it.
And some of our latest updates for those who are actually working with like the Smart on FHIR profile is we've updated to look at things like the audience parameter where it points to the server for the services. And most importantly, the importance of looking for UMA 2.0 and then also, yeah, those are the two major updates that we just did, that we're doing.
And noting this focus on patient-centric and patient centricity, can I say that word? Centricity. If you're looking for patient-directed health exchange, we've noticed in our collection of use cases that if you want someone to be proactive about choosing to share their health data, looking at efforts like consent to share that SAMHSA is working on, looking at a consent directive, for example, which is somebody saying, I would like arranging for my affairs when I'm, say, entering a hospital institution for a procedure, say, that pattern is very much an UMA-enabled pattern.
Right, and if you look at the specs, I'm assuming somewhere because you raised your hand about data segmentation, we also leverage some of the same codes, the security, the sensitivity, and the confidentiality codes to do a better alignment, to be able to do potentially aligning with the tagging type of things.
Yeah, we'll talk about that in detail in just a moment. Yeah. So we've got some pretty much brand spanking new work on a white paper and written use cases that makes some of this work come alive. This is not formally published on the website, but I think once we get back from Identiverse, very busy week here, we can put these links on the website. So because of the very new work coming out of the Centers for Medicare and Medicaid Services, did I get the 2 M's in the right order?
You got it.
We had seen out of the HIMSS conference in March, announcement about My Health e-data, which is precisely focused on patient-directed health exchange, and an effort called Promoting Interoperability, which is sort of the new name and new emphasis on what was called meaningful use, the various versions of meaningful use.
What used to be meaningful use is 21st century cures is another label that we keep talking about.
And these are actually exciting opportunities to do the right thing for interoperability, to do the right thing for patient centricity. There, I said it right. So we've produced a white paper that's called Enabling Patient-Mediated Health Data Exchange, and we worked with Jan Oldenburg from an organization called Participatory Healthcare. And use cases that are, actually a couple of these are out of review and approved by our group. Alice shares, we love Alice, shares clinical records with her spouse. So there's a real life use case that we see often. In real life, I will do it often. Alice electronically shares data from her personal health record, and sharing pulse oximeter data in a consented way with third parties. So there's a little IoT thrown in there. And we have some others as well. I think we've got about 5 use cases written up.
Right, and a big case is support of UMA is really around the delegation of parent to child, child to parent.
Yeah, so parent-child is really important one that comes up a lot. So, scope mechanisms that we have formally documented in our specifications and our profiles for interoperability. This is really key. So talking about confidentiality and sensitivity, this is the first way in which we're using OAuth and UMA scopes. So it's getting a little techie here. HL7 already defines many codes for sensitive data types. So for example, sense/ETH for substance abuse. I actually learned from a friend who's a paramedic that this came from ethanol long time ago, just in case you didn't know. So this particular code has a history. And similarly, HL7 defines a few codes that mean confidentiality levels, so just some simple codes for levels of confidentiality. So these are just codes, and we in HEART have chosen to profile the use of these codes, keywords essentially, as OAuth and UMA scopes. The way it works, if you're going to be a HEART-conforming service, is if you're a resource server and you are able to handle the filtering out of confidential or sensitive data of these certain types or levels, you document in your API, or if you're an UMA resource server, you register resources with scopes of these types that you can handle filtering or redacting of this data. And if an access token is brought to you by a client not containing these scopes, that's the signal that you do not deliver data of those types or levels. The absence of the scope is the signal to redact or filter. So this is the scope mechanism in these cases. There's another scope mechanism that we have that is somewhat similar. Break the glass. HL7 also defines a code, BTG, for break the glass. This is for situations when the resource owner is unavailable. So HEART uses this code similarly. It defines a scope. This is for interoperability. Again, in this case, the scope is associated with an access token such that if the scope is present in the access token, the resource server must log that access was given to, let's say it's an emergency responder. The resource owner is passed out. They can't, at that moment, give access consciously, whatever it is. Now you might be asking, well, who set the parameters for when they're going to be giving access? What were the conditions for them saying, yes, I agree, if it's an OAuth scope, to give access? This is a matter for where trust frameworks come in. And maybe you can say something about TEFCA.
And then another thing, so the way that the HEART profiles are built, they're layered OAuth, OpenID Connect, UMA on top. you may adopt one or many of them. So from basic OpenID OAuth exchanges to have the parameters, the scopes available, but there is the potential for those covered entities, those hospitals that are required to or have the ability to do the exchange through the use of UMA using resource sets to be able to proactively advertise and claim that these are the abilities that they can be due. I think it's a really powerful point that hopefully over time that industry will begin to get a sense of how they could use.
So yeah, this notion, for example, of break the glass is something that a user's policy could set. It may be a matter for a default policy that is offered in the context of an authorization server. And there is work actually going on for a standard for a trust framework where the offerings of those services would make clear that only qualified first responders, emergency responders who are perhaps verified and authenticated to a certain level of assurance could be.
So you must be talking about the TEFCA as we're talking about for
TEFCA.
the formal. So under the 21st Century Cures, part of the mandate was to set up a trust framework for the matter of exchange. It's in draft for right now, and certainly they have set some standards of using the IHE profiles, moving to FHIR and support. They are using AAL2, level 2 of the very much following NIST 863-3, and certainly all of these could actually work into that framework, and that is the hope.
And in fact, there is a group run by the Karen Alliance that is working on actually profiling for verification and authentication in this context using 800-63-3, so now we're talking standards on top of profiles, in order to get interoperability of such things. And a number of us are participating in that effort as well. So you've got trust framework, 863-3, profiling for usage of levels of assurance effectively in a health context. You've got HEART on top of all these many standards and great work on top of HL7, and kind of all of that coming together to have what in a previous session I referred to as the BLT sandwich, business, legal, technical. It all has to come together. As I'm sure everybody knows, technology isn't everything. You also have to rely on all of those operational policies, business policies, law as well, to ensure that you're doing right by that patient, by that consumer.
And
as
also
well.
this is an incremental journey. At first, when a lot of the work around FHIR, it's been out, I want to say, since 2014. And most of the work was just within a hospital unit, provider to provider. So as they expand out and as the mandates to have patients have access to their data and to be able to do more frequent exchanges, over time we're going to see these profiles become more strengthened, stronger, and evolve over time.
Yeah. So one last word about how else to use the scope mechanism. One of the things that the group, the HEART group, is discussing at this time is a potential way to have another scope around de-identification. So you could have an individual say, I would like to share data with, say, a research organization or for, heck, marketing purposes, as long as the data is de-identified to some level. So we're discussing this now. Every one of these sharing scenarios could be fraught, we realize, but this could be another powerful way. If a resource server, again, can handle de-identification, the scope mechanism is kind of cool. So that's work going on right now. Last thing we can talk about, why don't you just talk about the Move Health Data Forward Challenge, because this is your baby. It is?
So the part about the OpenID Foundation and the building of profiles, they're implementers drafts, and they don't change to full drafts until you have evidence of implementations in the wild. So a way to inspire this, we actually had a challenge in 2016, leveraging heart profiles. And then it did two things. It raised awareness to the heart profiles and the sharing, but it also gave input back to us for updates and improvements onto our spec. So it ended up being, it was a multi-phased approach that I think the lead teams got up to $75,000 for their work. And it looked at various things. It not was just the PHR, but there was one that looked at advanced directives, and it was a very sorted of different things. And so what we find is, as we've gone on, we've actually had these companies that are moving on and actually supporting heart in other areas as well. So it was a good place to start.
So one quick word about additional work that's building on top of heart and other standards. This is a complex diagram. Normally I'd sort of do a big build. I just wanted to show that there's something called the OpenMedReady framework that I'm involved in along with ForgeRock and 5 other companies. So you can go to openmedready.org to learn more about it. But the idea is, if you need chip-to-cloud trustworthiness of smart devices in a healthcare context, so that you can get trustworthiness of remote care data or smart device control. For example, this is a pulse oximeter from a company called Nonin. And you might be using health clouds from a different company, and you might be using authorization services from a different company, and you might be using some hospital, and you might be getting a second opinion from some other doctor, and you're using some insurance company that's different. You really have an interoperability challenge. You might be having fraud challenges with insurance. You might be having, the patient wants to be sure they're getting the right diagnosis. The doctor wants to be sure they can give a right diagnosis. How can you do what's known as, I'm going to try and say it in the subject matter expert way, provenance from the device? You need to solve all these problems. Provenance, I always say provenance, identity, consent, and proof at every stage. So that's kind of all the steps that you have to achieve. And so OpenMedReady is actually working on this proposition, building on top of not just Bluetooth standards and FIDO standard and OAuth and UMA, and HEART is in there because it's already solved some of the problem. So you can check that out at openmedready.org. And with that, if you have any questions, let us know, and Greg can help us out.
Thank you, Eve and Debbie. Very fascinating stuff. If there are questions, please put up your hand. I'll bring you the mic because the session is being recorded.
First off, love that you're doing multi-protocol support. In that regard, are the capabilities, the HEART capabilities, are they kind of on par between the different protocols, or there are some capabilities that aren't supported if you're using OAuth versus UMA versus what have you?
I'm not sure.
I would say, I think that they are equivalent. So for example, the scope mechanisms apply either way. But other than that, it just sort of depends on the protocol's capabilities themselves. So for example, vanilla OAuth doesn't have resource registration. UMA adds on top of OAuth the capability to loosely couple an authorization server and resource servers. So it gains that if you use UMA.
Okay, what about delegation, where I'm not sure OAuth has anything native for delegation either?
OAuth is a delegation protocol, but it delegates from a resource owner to apps.
Yes.
And UMA adds delegation from a resource owner to requesting parties using apps.
Okay.
So it's just native to the...
Asynchronous, and it's an asynchronous delegation.
Yeah.
The idea to be able to set many of these preferences, if a resource server would support that, to be able to have some of these preferences set ahead of time, there's some powerful potential that they may be doing with other resources, but it might be a standard way to be able to do that.
Yeah, so that's kind of what I meant by the sort of patient centricity. One of the things we noticed early on was, OAuth grants out of the box, looking at 6749 and the other grants typically, they tend to be opt-in in their nature typically, which has limited effect sometimes if you're looking for a consent directive kind of effect. UMA is asynchronous by its nature. That's what it was designed to do. So it's a pretty good match for the more patient-centric kind of model. And so that's just a native feature that matches pretty well a lot of the use cases that we were collecting.
And I think it's really important to know that these profiles aren't necessarily replacing existing access control and authorization methods, but it's certainly giving standards and methods to be able to express them in a standard way. So certainly your XACMA or whatever type that you have that could set some of these authorizations and things, or this is just a way to help enable that.
Yeah, but the profiles themselves are within that framework meant to be even. And in fact, if you look at the UMA security profile, the mechanical profile, it mostly points to the OAuth security profile where it can.
Okay.
And similarly, the semantic profile mostly points to the OAuth semantic profile where it can. Similarly for the OpenID Connect profile.
Great. One
Thanks
more
for the
question.
Yeah.
I also noticed that you don't have anything in the HEART initiative in regard to FIDO, and is that because it's not needed, or just if you could answer that?
That's a good question. So we have not felt the need to date to profile for, say, assurance levels, authentication assurance levels, because mostly that is a matter for the business decision of the strength of assurance or authentication you need, and we have put out-of-scope trust framework elements quite firmly. So it's probably a matter for the Karen Alliance group that has come up in the last couple of months that shares many members, group members.
But certainly,
with HEART.
during the exchange, the idea of being able to express with the auth and context, and maybe looking at the work that's coming out of the vectors of trust, and being able to describe these higher levels of authentication and authorization to be able to use. I mean, that is something that, again, the specs could leverage, but it's kind of out of scope for what we're doing.
Yeah,
but
it's technically
at least
out of
part
scope,
of the profile would be included.
And we've talked about writing auxiliary
Standard,
documents to illustrate some things that could be done, so that could be on the docket as writing non-normative documents, and I think we need to wrap it up now. But we could talk offline.
Yeah, feel free to talk to them both offline. This concludes the healthcare track. We hope you found it valuable. This is the first time we're doing this at Identiverse. If you could, we'd really appreciate if you went into the Identiverse app, check in for this session and the other sessions you've attended, and please give us a feedback just so we know how well this worked out. Thank you all for coming. Have a good rest of the conference. Bye.
Thanks.